Good evening, everyone. We are back for another Fertility Q&A live, and we'll be joined tonight by Dr. Kenneth Gelman of Ivfmd. For those of you who don't know me, my name is Dr. Farrar Duro, and I am an acupuncturist, or reproductive acupuncturist in Hialeah Gardens. I do see Dr. Gelman, but he is in his own account, so maybe he'll switch to the Ivfmd account, and we'll be able to beam him in. And let me just adjust my volume here. So we'll wait. Hello, Allison. Hello, welcome everyone. We'll wait for Dr. Gelman to switch his account over to Ivfmd, and then we'll get in soon. So if you guys have not submitted your questions, don't worry, you can actually type them in the chat and the comment section, and then also you can hit the question button, and that actually can show your question to everybody else, because most likely they have the same question. And as long as we've been doing this, we always get really interesting different questions that are applicable for so many people. So I think you're helping others when you ask questions. Don't be shy. This is also National Men's Health Month, so we're going to hopefully get some questions from the guys tonight too. We really welcome questions from male and female about reproductive issues and fertility and all kinds of issues. But I know with male fertility, sometimes it's not talked about as much. We don't see the guys in our clinic as much sometimes. So, I do see Ivfmd joined, so let me go ahead and invite him in. And Dr. Gelman, who's joining us, he's excellent with male issues. So,
hey,
here we go. Welcome.
How are you?
Good. How are you?
I'm good.
Very good. I was just mentioning this is National Men's Health Awareness Month.
June is it?
Yeah. So, and we talk a lot about female issues, but hopefully we can talk a little bit about male issues too, male fertility. There's always lots of questions around it, but we don't sometimes answer it as much. So, so don't be shy. If your partner's with you, you can have him join. And also please share this with your friends who might be struggling. It's definitely more common than you know. Now 1 in 7 couples honestly struggling with fertility issues. So, we would love to help anyone there that needs help. So, so Dr. Gelman, if you could introduce yourself as well too.
Hi, I'm Dr. Gelman from Ivfmd, one of the many doctors in the Cooper City location. We've been doing this just about every month. I think we missed last month.
Mm-hmm.
It seems like longer, actually. We just
it's been a while. Yeah, I know.
It really does. Yeah, we enjoy doing these every month. So I hope a lot of people out of you are watching somebody's watching from Nigeria.
Oh, that's so cool.
Wow. Wow, we're really reaching the world today. That is so cool. Hi, Nigeria.
Hello.
That's really cool.
That's neat. I mean, like the goodness with technology now is we can
amazing.
Help people in other areas. With virtual
sessions.
Oh
my God, that's amazing. Yeah.
I think it actually forced us into the future in some way.
This is just great. Yep.
So we do have some questions that we're
in Canada. Somebody's in Canada.
Oh my gosh.
Hey, hi Canada.
Oh, awesome. So, yeah, why don't you just type where you're listening from? We'd love to know in the comments section. We actually are going to be answering questions, like I said, that were pre-submitted, but also if you guys hit the question mark and below, you can actually type your questions in and we'll pop it up on the screen so everyone can see it. And that way we'll help other people as well that have similar questions. So, we have lots of questions tonight about acupuncture, preparation for IVF, what to do when you're pregnant as well, and lots of acupuncture questions in the beginning. So I guess, well, I can answer that, and I know you've worked with acupuncturists for many years, so I'd also like to hear your input as well on what you think has also been helpful for your patients. So
right.
So we are going to just jump right in then. Would going to 1 or 2 acupuncture appointments be at all beneficial? And I think this is maybe I'm not sure if it's referring to a medicated cycle or what type of treatment that they're doing. But, I think like some is better than none, and especially for the stress relief factor even, just to try to go for that. It's cumulative. So just like going to the gym one time, it is not going to be harmful unless you really overdo it. But acupuncture is pretty gentle. If that's all you can get in, then maybe you can time it around whatever treatment you're doing, and you can talk to your doctor about, your treatment plan and that sort of thing. What do you recommend?
Well, yeah, two, it obviously depends on exactly what you said is, when these treatments are going to be done. I mean, if you're just first starting your workup and your evaluation, getting one or two treatments isn't really going to do much. I guess it's like kind of like almost like if you go for a massage, hey, it's great, but the effect may last for a day or two, and but I think in that context, I think if there was only going to be two treatments, then I would probably insist on them being done, at the time of transfer.
Mm-hmm. Okay.
That probably makes the most sense.
Mm-hmm.
So at least you have the benefit at the time of transfer, but it's much better to do this 6 weeks before and get, 2 or 3 treatments a week. It's the tough thing is going to be adding it to your schedule.
Yes, and I mean that's one thing we learned many years ago is that before the pandemic hit, also people are busy. They have to come in after work a lot of times, so we have our hours, usually kind of catered to patients who work as well. I mean, we're there till 7 usually at night, so except Wednesdays when we're here, but 7, and then on Saturdays as well. So just
that's very good. The Saturday hours are great for you.
Yeah,
you must be very busy Saturdays.
Saturdays are pretty crazy. We usually book a few weeks in advance for that, but we have a lot of couples that come in too, which is great. Families, like I love seeing families. And I found with PCOS especially, we have that runs through generations. So sometimes we'll have a whole family with PCOS that we're treating, like sisters, the mom. It's very interesting. So anyway, so that's kind of what we try to do. And with another acupuncture question, I'll just kind of tie it in. Someone says, should I consider, can I continue acupuncture once pregnant? And, we definitely do recommend that because of a lot of reasons to help with nausea, vomiting. There's a lot of research on acupuncture for nausea, vomiting prevention, even with cancer treatments and things like that. They do use that for, but it's safe. And there's definitely some good prenatals out now that have ginger, and they have different things as well for nausea, but we like to go ahead and treat the nausea before it even happens, so we're doing points after the transfer, like 4 to 5 days after for that, but also for stress relief. I mean, that's a really stressful time as well.
I think you should stress that because a lot of patients, who get nauseous, they may not necessarily think about acupuncture and things like that, and the doctors certainly don't.
Mm-hmm.
But once the patient gets nauseated, the treatments are not very good.
Yeah. Oh, yeah.
I mean, you're going to start in with Finnegan suppositories and all kinds of things, and I don't think so. I mean, I'd rather not. I mean, the OBGYNs, deal with that a lot more than we do. But, Diclegis, it's an approved FDA drug. It makes you very tired because it's full of antihistamines. It's expensive. And, it's very hard to take. They can't take it during the day, really. I mean, you take it in the morning, but it puts people into a coma, So, and then, Zofran, had some negative press about some birth defects or something in pregnancy, although people are still using it.
Really? Okay.
So it's not the best, let's put it that way. And I'm not, I use it every now and then, but, I'm not a big fan of that. So maybe acupuncture might be a better way to go.
Yeah, it's interesting when we start the treatments after transfer, we don't know if you're pregnant or not. We're hoping. And majority of our patients are pregnant, I think. I mean, there's definitely a good chance of that. But when we're waiting, there's a lot of stress. There's a lot of symptoms that are happening sometimes, or sometimes no symptoms, and that can be stressful too. And we're doing those nausea preventative points along with stress relief points and blood flow points. And then, when that sort of time comes at 6 weeks or so, and it kind of kicks in, it's not as severe. And that's what we found because we did our own little informal study. We're like,
we really should think about that because it's something, we don't think about as often, and we really should.
We knew when we were actually not treating patients and during May of 2020 when we were closed and we had patients who were newly pregnant that were vomiting. And we're like, wow, we haven't seen that in a while, you know, because most of the time our patients are not that sick, you know, they feel pretty good.
Yeah.
And so I would call you guys and be like, what can we do? Because I can't see them and you know, what can we offer? And their OBGYNs were either, you know, it's hard to get in touch with or get an appointment. So anyway, we just, you know, had at some point to realize that this is important. We want people to enjoy their pregnancy. They really work so hard for that, that moment. So we try to work with that. And then also for pain relief. So during pregnancy, you can use acupuncture for migraines, migraine prevention, lower back pain, neck pain. Many of those things where we used to, they'd say just take a Tylenol, but now not really like clear about Tylenol in pregnancy and if we should be doing that. So that's one thing you can do that's safe along with massage. So definitely that. And the other question about timing about acupuncture during IVF from a different person was how often should you go? And we talk about this a lot, but I think strategy wise, we try to ask our patients to come twice a week during that 4 to 6 week time period if they can. Because that's kind of like crunch time, whether you're doing a fresh transfer or you know, stimulated cycle or preparing for frozen embryo transfer, there's a lot going on. There's medications that you're not used to taking. Some people get a little bit, you know, a little bit side effects from sometimes the estrogen or certain medications are on or Lupron. So we work with those things. And then also the stress that comes into that process and helping with blood flow. So we're going to do different types of treatments with like electroacupuncture, sometimes a little massage, different techniques like that. So we're trying to work up to that point where you get to the transfer and you're feeling good and relaxed and positive and hopefully, you know, you can do acupuncture during your transfer as well, the pre and the post treatment. And then we see our patients back still twice a week until the ultrasound shows a heartbeat if they are pregnant. That's around that 6 week mark, and once a week during the first trimester. So that's our protocol. Everyone will have different protocols, but that's just kind of like most of the reproductive acupuncturists are going to be using that similar protocol. And some people have a long wait before their transfer from the time their embryos are getting tested, or maybe they're doing other stimulations. They're trying to get as many embryos as they can and bank them. So sometimes you have a long period of months that can go by, and might as well use that to your advantage, I think, you know, and do everything you can.
No question, because, you know, a lot of times, well, not everybody, but, you know, some patients as they're going through their evaluation, you know, we're making sure that their diet improves. You know, we discuss that with them. We may have them see our lifestyles counselors, and we may be working on their weight or whatever it may be. And, you know, that's the time to get your acupuncture too. So you're improving a lot of things at once, you know. So it would be a perfect time not to waste that time. Definitely. Because you're doing 2 or 3 things at once.
Yeah, and it's not everyone kind of goes into thinking, okay, I'll go right in and I'll get my transfer done and I'll be right. And it's like there's a few things.
Yeah, well, you know, it doesn't work that way.
Yeah,
it really doesn't.
It's not an instant process.
It's a process. You know, when people walk in, they're really surprised sometimes that the process takes a little while. It really can take several months sometimes.
Yeah.
To really get this done, you know. I mean, obviously people have lived their lives. They have vacations and things and work commitments and things that, you know, delay things, or, you know, our schedule, you know, gets backed up and we have to delay things. But the process takes a while. So while you're waiting for your, you know, your stimulation to start or for your transfer, that's the time to really take advantage of these things. That's why this is so important, that these sessions that we're having now, we can explain that to people, because people really, I don't think, understand it. No. How much of a benefit you can get from acupuncture, healthy diet, stress reduction. I mean, we're all living with that every single day. Every one of us has stress every single day. And if there's and especially in this field, I mean, this is a very stressful, emotional process, extremely so. You know, and people really have to be aware of that, even though, you know, you might be the best candidate in the world for IVF. It still can be very stressful, and it's not 100%. So you have to be aware of all these things and be able to deal with the ups and downs that may occur.
And I think there was a study in Australia that tested resilience. They found that the people who were getting acupuncture had more resilience to go into that next cycle if they needed to, and I
Yeah,
think that is you like you look at it like a marathon. It's not a sprint, So we're getting to the next mark, and each time you get the reports back and all this data that you're getting about your body, sometimes it can be stressful as well. It's like more about your body than the person
right.
sitting next to
And,
you.
and and for many patients, it's very expensive, and this may be the only time they could possibly do this,
Hmm.
and believe me, we hear those stories, and we hate hearing them. But
Yeah.
let's make it work. Let's do everything we can possibly do that could affect your outcome in
Yeah.
any negative fashion.
Let's put the odds on your side, hopefully, and that's
Well,
what
control the things you can potentially control,
right.
because there's a lot of things you cannot control. But
Yes.
there are things that are definitely you can control in your life, or
Yeah.
certainly make a very good effort to control. That's what
Definitely.
this is about.
That's very well said. I
Yeah,
agree. Yeah.
yeah.
And as far as there's a question that popped up about PCOS. So could you, let them know like what labs do you recommend for a PCOS patient? So
Well, I think PCOS. Actually, the Fertility Journal. I think it was last month or month before. Very interesting. And that actually comes on the heels of what Quest has done. Quest Lab. They came out with a really good cardiac risk profile that looks at not only cholesterol and LDL, and looks at all these biomarkers of inflammation and LP little a, and very complicated lipidology, I would
I
say.
love that Quest
And
cardio.
yeah, they came out with an absolute winner panel. It's a great
Mhm.
panel. And it's funny because the Quest rep came in and showed me this, and I really, really liked it. And I asked that they give us an in-service to the nurses and stuff, because I'm going to start
Yeah.
potentially ordering those things, especially on PCOS patients who have metabolic issues associated with them, because many 40-50% of them do,
No.
where they may be weight challenged and have insulin resistance, or really documented insulin resistance, or pre-diabetic, and
Hmm.
have lipid abnormalities and things like that. And that would be a real good profile to get, because there's now, as this new, these 3 series of articles in the Fertility Journals really clearly outlines that metabolic parameters are very important in terms of fertility
Hmm.
also, because there may be factors. I think somebody asked about LDL, whether that's going to interfere with your fertility, and it does.
Yes.
There, there, there are studies that clearly show people with high LDLs have lower fertility rates and have higher miscarriage rates. So those things really need to be dealt with early on. And the sad thing maybe is that we're seeing these patients when they're coming in to get pregnant, 99.9% of them, and we're not going to be able to help them manage that kind of problem that effectively, because we really want them to improve as much as they can, and get pregnant as soon as they can. Um, I think the other physicians involved in their care should be looking at these things, especially pediatricians. I think this is maybe a wake-up call for them too, to start
Hmm.
looking at these things early on, maybe treating patients with high LDL, and not just necessarily putting them on a diet. Maybe patients need more some kind of treatment. I mean, statin drugs wouldn't be good in pregnancy, but maybe up until the time of pregnancy,
Hmm.
and diet, it might be a reasonable thing for some of these people. So to answer that question, I think laboratory tests for PCOS patients should include this cardiac risk profile that Quest does, in
Definitely.
addition to maybe a glucose tolerance, or at least a fasting sugar and a hemoglobin A1C, obviously testosterone, androstenedione, which are male hormones, DHEAS, thyroid profile, obviously, a CRP, which will be
Yes.
included in this cardiac risk profile. Sex hormone binding globulin gives you good evidence of insulin resistance, IGF BP1 is another test that gives you evidence of insulin resistance. A cortisol, possibly post-dexamethasone, if there are any symptoms compatible possibly with Cushing's syndrome. There's no, somebody hasn't had that done, where Cushing's syndrome could be a possibility. That's got to be ruled out too. 17-hydroxyprogesterone in the follicular phase, early phase of your cycle has to be done too, if that hasn't been done, to make sure you don't have something called congenital adrenal hyperplasia, which is an adrenal problem associated with high male hormones, very similar looking to PCO. And it may coexist with PCO, more common in Ashkenazi Jewish people. So that test has to be done too. So that sort of gives you, I think, a basic idea of the tests that we would do. Ultrasound of the ovaries, and obviously a history and physical exam and, that kind of thing.
Definitely. And it's so important to get a full PCOS panel, I think, because many people don't, like, they come in and they maybe just had their FSH and a few things tested, but it's like, no, there's so many components to PCOS,
Well, specifically with that question, people always say, well, I don't have a reversed FSH-LH ratio. You may not have that. That may be one thing that, your gynecologist might be attempting to grab or find, but that may not exist. So, all those other tests really should be done. And you don't have to be overweight either to have PCOS. So, don't think that that's necessarily the only criteria you have to have, or, you don't. You can be thin and have PCO. And
we've seen younger and younger. I mean, we had a 20-year-old patient that had all the cardiovascular markers elevated with PCOS. It's not that because you're a teenager, because you're in the early 20s, you shouldn't worry about your cholesterol. That's when you need to worry about it.
Well, that's exactly right. So that patient, I would refer to a pediatric cardiologist or something like that to manage that. Being
20, I guess you'd be an adult, right?
Well, even, maybe an adult or a pediatric cardiologist, whatever. 18, some of them are still going. I mean, whatever, somebody like that.
Yeah, it's a 20. Yeah, and and there was a question about CRP also. If CRP is high, how can I lower it and the associated inflammation? Because I know that's a big one now.
Well, that kind of goes hand in hand with what we're talking about here. If you have insulin resistance, if you're overweight and you have, elevated lipids and, high triglycerides, low HDL, maybe a high LDL also. If you have a little hypertension, I mean, you could be syndrome X, which is another type of syndrome associated with insulin resistance and hypertension and obesity. But, if you don't have any of those things, I mean, we have to look for potentially why you have an elevated CRP. Now, obviously, if you have some kind of inflammatory disorder, like God forbid lupus, anything like that, you're going to have a high CRP. If you have an infection, you're going to have a high CRP. But, a CRP at 3, 3.5 is usually indicative of some other metabolic process, maybe even gingivitis. Because I've seen people with gingivitis have that.
Interesting.
So take care of your teeth.
The reason I go, there's a dentist question here. So
well, yeah. I mean, you go to your dentist and make sure you're getting your cleanings, but not only that, make sure you're getting rid of any gingivitis that you might have. So make sure you ask your hygienist if you have that, because that's contributing to inflammation. Inflammation in your body is going to cause inflammation all over your body.
Makes sense. Yeah. Yeah, right. Because there was a say about that, about how.
But to answer that question, also, what I do for that is put people on fish oil, EPA oil. I put them on 2 to 4 grams a day of EPA oil. It's got to be, the EPA, not just fish oil. You got to look at the EPA content. And a baby aspirin a day, and work on other factors that might be there if they're overweight, or maybe metformin in some of these individuals. It depends on the situation there. But that's a good question.
Yeah, and inflammation.
Because you don't want that going into, or if you had an IVF failure and you find something like that. you have transfer failure, then you'd want to treat that.
Mm-hmm. And I would say with COVID, I mean, now COVID's going up, right? These cases of COVID, you hear going up. That can elevate your CRP also, right? I mean, being sick.
Sure, sure. Well, yeah, generally, I mean, it'll be fairly high with those kinds of things. Mm-hmm. 7 to 10 range. There's sometimes when you get a CRP that really high, like 10 or 15 or something, it's usually a non-specific. You don't really know what's doing that.
Okay.
A 3.5 is usually insulin resistance or maybe like gingivitis or something like that, something more occult, not so blatantly obvious.
A lot of women with PCOS have high CRPs because it is an inflammatory condition.
Yes.
And it will definitely fluctuate a lot of times too. So it's kind of
it will.
Very frustrating. Know? But yeah.
That's a good question.
Mm-hmm. And I've just thrown the dentist question because someone asked, how safe is the dentist during IUI and after? I mean, definitely before you should be.
Yeah, before it's fine. I mean, if I think I would not. I certainly wouldn't do X-rays at the time of after you get your IUI and you're waiting to see if you're pregnant and implanting and things like that. Mm-hmm. I mean, but before that, you should be okay to do things like that.
These are really good questions tonight, guys. They're really good, and I mean, I think it's crazy. As long as we've done this, we always get different questions and good questions.
Yeah, they're always good ones. Yeah.
Thank you. Let me actually pop into this question chat here so that you guys can see this. So I'm going to bring the question up right there, and you can see it too, Dr. Gelman. Mm-hmm. It actually cuts off a little bit. So let me see. I've had an unsuccessful egg retrieval that 0 eggs fertilized out of 10 at 32. Oh, man. Then I got pregnant naturally 4 months later and pregnant now 3 months. Awesome. Do I have a good chance at all for baby number 2?
Wow. Your first egg retrieval, you had 0 eggs fertilized of 10.
Of 10 at 32 years old, yes. And now pregnant naturally 4 months later with, I think it says I'm pregnant now with 3 months. Do I have a good chance at all for baby number 2?
Sure.
Well, congratulations first
Absolutely
of all.
You do. Now I'm wondering what did they do with your eggs? Were they ICSI'd? Did you have ICSI? Because why would you have 0 fertilization?
Yeah.
That just, I mean, you must have had immature eggs or something there that was very odd. Especially since you've got pregnant, right away, or seems to got pregnant soon after IVF, which is another question I think I saw. Not unusual. Yes, it was ICSI. Yeah. Well, obviously you do better with. They were all mature. They said quality something. What?
Quality.
Quality. What kind of quality? Quality good, bad? Do you know?
If they didn't fertilize, I guess she's saying that there was a quality issue. Maybe.
Huh? I don't know what she said. So I don't know what quality means. If they were good or bad. They said egg quality what? Egg quality bad. Mm-hmm. Yeah. So that's peculiar. I mean, that suggests something with possibly the fertility drugs, because you got pregnant naturally. Maybe you need I mean, I don't think you're going to need obviously IVF again, but something's with your ability to, mature those eggs and have them possibly at the right stage where they're, they should fertilize, but I don't understand what happened there. I'd have to actually ask the embryologist what the deal was. But obviously in a natural situation, you get pregnant. So, clomiphene and natural intercourse, have they tried things like that on you? Or letrozole. I mean, that seems like something that would have worked. So I'm not sure what happened in that situation. It's very, very odd.
And then there's someone commenting, same thing happened to me twice, low response in all cycles, no fertilization in 3 of them, no implantation in 2.
What was that? I didn't see that.
Oh, there's another, it's in the comment section here. Someone is just responding there. And I mean, I guess every cycle is different too, right? Um, oh.
Well, yeah. There's no question,
Hmm.
but it doesn't make a lot of sense in terms of having 0 eggs fertilized of
Hmm.
all 10.
Hmm.
It's something's odd there. I mean, something is really up. And then you got pregnant on your own right after that. Something
You're,
really doesn't make a lot of sense.
I didn't recognize her
Unless,
name.
huh?
I didn't recognize her name, but she went to us. So, Picante Queen. Congratulations, though. Either way,
Yeah,
however
yeah,
it
I know.
happened,
It just
awesome.
doesn't ring. It's very hard to understand what happened there. Yeah,
Well, maybe we're gonna have you on our Instagram one day. We can talk about these things because
yeah.
I think it's like every person is unique, every situation is different, and it's sometimes it's just very it's there's an art to it. You know who it is, love you. Well, and I'm just also confidentiality. I don't want to like tell
No, no,
anybody's
no,
name.
no, no.
So let's give another question here. And our little pop. I love popping these questions in. That way you guys can see everything. Okay, I'm 31, trying for 1.5 years, just diagnosed with PCOS and insulin resistance. Put on metformin last week. I've been on letrozole 2.5 milligrams for 5 months. On letrozole day 21, progesterone shows ovulation. Any supplements to suggest? Um,
Well, you're on metformin. You're on good things. I'd probably try ovasitol. I think that's a pretty good supplement. I'd
mhm,
add that. CoQ10. I'd make sure I was taking something like that. Fish oils.
mhm. Yeah.
I think, and obviously a prenatal, those kinds of things. Um, and make sure you're following your healthy diet, getting
Mhm.
some exercise, and you're reducing your BMI if it's elevated.
Definitely, yeah. I agree with all of that. And there's something to the Mediterranean diet.
Oh, she has a block too. Oh, okay. Well,
Okay.
that's also a little bit of a difficult problem because you've got to also monitor what side you ovulate from because you won't know by ultrasound because otherwise you won't know whether trying that month is going to give you a chance to get pregnant or not because it's not likely the egg on the block tube, the ovary, if the block tube is the side you're ovulating on, is going to get to the other side. It's not that likely it's going to happen. Very low percent
Mhm.
chance. So you want to make sure you get an ultrasound mid-cycle when you're doing your letrozole or whatever you're doing so that you're getting an egg on the good side. That's the side you should trigger your ovulation and try. Um, Otherwise, I think, potentially it's going to take you possibly a lot longer if you get pregnant at all, this method.
And I mean, definitely since the other one's open, there's a good chance it
Well,
can.
there's a
Yeah.
chance, obviously. At least you'll know
Yeah.
that you have a shot.
Hmm.
So make sure you're getting an ultrasound at your gynecologist's office or wherever you're at.
Yeah. Definitely. And I mean, there's some things that we found that have been helpful if they're just small blockages and not overly scarred and everything.
Well, that's the other thing is you never know, is the tube really blocked? Sometimes you have spasm, you're repeating HSG a couple of months later, or you give the patient Valium to relax them because it's a very nerve-wracking procedure.
Hmm.
Um, and you repeat it, and the tube's open. So
Hmm.
you could also do that. That's a good point. You could actually repeat your HSG.
Hmm.
If you're not pregnant after a couple of months of trying, and repeat it and just make sure that tube's blocked. Or I mean, this laparoscopy. I mean, I probably wouldn't do that. I would just do an HSG.
Oh,
The
the HS
blockage is at the point where it connects to my uterus. Yeah, yeah.
is
It
still in.
probably it probably is blocked.
There, I mean,
Um,
there
so
might there might be some benefit into doing a little bit of fertility massage. Like we've had a few patients where it ended up opening, and I think it's worth a try. It's not 100% but the last 2 patients actually did have good results with that. It's a deep massage, almost like a physical therapy technique. Sometimes it can help a little bit with breaking up scar tissue. And then we use systemic enzymes, that are also helpful for that too. So it's like usually you'll know within like 5 or 6 treatments if that is working for you. So there is another group that does that, I think called Clear Passages also. They do that. And it's not an incredibly relaxing massage, but it is.
Well, it might be worth trying it. And, if you're willing to go through another HSG, do it again just to be sure.
Mm-hmm. Yeah. So definitely.
Take 800 milligrams of Motrin too.
Yes. Yeah. And where there's a will, there's a way. That's what we say.
Yeah.
What's the success rate for using acupuncture and getting a successful transfer? I think it also depends on which clinic you go to, definitely. Obviously, like you guys have a very high success rate, and we work a lot with your patients. And I think last year when we did we haven't done 2022 yet, but 2021, it was it was between like 85–90% of our patients ended up pregnant who were going through FET. When we were there present at the transfer, which was very good. And I think that was probably due to a lot of times, it used to be around 70%. So I think it's become higher with the genetic testing going on and the things that you guys are doing, also with the lifestyle and the everything that you do. I think it could really contribute. So yeah, I mean, everybody's different, obviously. Everyone has, but I think that you guys pretty much cross every box and you try to make sure that every single rock is overturned, that, you're not getting to the transfer and going, oh, we should have done this, So I think.
Yeah. No, we always try to cover those bases,
Yeah, definitely. And I mean, most studies have shown it's about 30% increase if you're doing acupuncture during that time or during the transfer. There's a little bit of a difference also with patients who are doing it prior to. So there was a 6-week study, 6 weeks prior to the transfer versus at the transfer. That was actually a little higher. So, but obviously if you're going somewhere that you can look on SART, that's what I always recommend, like going to SART.org, SART.org, and you can check the success rates in your area, wherever you are. I think it's worldwide, or is it just the United States? I'm not sure.
I think it's U.S.
U.S. only. I mean, there's already websites of the clinics that you're going to. A lot of them will publish it on their website. So hopefully they'll, have good rates, and it really varies too. I see huge variances of it. Just wherever you go, just check that for your age range as well, right? Do you recommend that resource or any other?
No, it's good. It's useful. I mean, I think, people want to see and they want to know.
Mm-hmm.
It's useful to see in your age range how, one clinic maybe is doing versus the other one.
Mm-hmm.
But, many people also go by reputation. Mm-hmm. And, where their friends said they should go, they've had a good experience,
mm-hmm.
So they go by also a lot of that.
Yeah, that is true. Yeah, and I mean, definitely do your research. I think that even just, based on your country, because many people are even not from the United States that are watching this, maybe in different countries, they have different protocols and different things. Sometimes, you have to go outside of your box. Some people come here. Well, you had a patient do a transfer in South Africa actually last month, and and then some people coming here from other places. Like I know you guys see a lot of international patients. So.
Yeah, we see a lot of them. They come here. Well, we do a lot of their monitoring necessarily. Some of the times in other mm-hmm. places, and then they'll fly here just for the, the transfer or the retrieval or whatever they're doing.
Yeah.
So we can work with a lot of patients in different countries.
Yeah, definitely. And I think we have another question that popped up here too. A few more questions. Okay, well, actually this one is the one we haven't seen here. Maybe this is a follow-up question. Oh, will my good tube travel between ovaries if I have one blocked? It can reach, right? Sometimes.
Well, it's rare. It's very, very rare. It happens.
Yeah, it happens. It happens. Yeah, it's hard to.
I would not count on it.
Yeah, structurally, like it can do it, but we've had one patient that happens. It was so many years ago, but I still remember her because she had
everything's in fluid there. You can kind of swim over there.
Yeah,
but it's not something that's going to happen with any high degree of certainty.
there's a lot that has to be orchestrated, right? A little fembrae have to kind of, reach and grab.
Yeah. There's a lot of physiology that involved with how the tube actually grabs the egg and things like that. It's kind of beyond the scope of this, but
Right.
just at least know that the possibility of that happening could occur, or that tube really isn't blocked.
Mm-hmm.
We think it's blocked and it really isn't blocked.
So, yeah, it could be like a functional thing, right? There is a question of 41 years old, low response to ovarian stimulation, no fertilization in 3 cases, 2 transfer failures, no implantation. What is the rate of success going to embryo adoption?
Well, embryo adoption versus donor egg. I mean, those things are probably, I guess we should talk about them together in a sense. I mean, embryo adoption, first of all, is where couples can adopt, embryos that have been cryopreserved from other couples, from other clinics or other agencies that store these things. It's a little more of a complex process because it's almost like a regular adoption, because they're gonna, have you go through all kinds of screenings and things like that, just like you would in a regular adoption, and it's going to take a long time.
Mm.
And as opposed to, and it's an embryo, so obviously the success rate of that will depend upon how, the embryo that you get and the quality of the embryo, the age of obviously the patients who created the embryo. So all that's going to affect the implantation potential of that embryo. As far as egg donation, frozen egg bank, that's a very, very streamlined process now. That can, probably happen in 3 months or maybe 4, because, the requirements are fairly straightforward and easy. And as long as you find your donor egg through the donor banks that we use, and we prove them, that process can be done. It's usually in 3 or 4 months, it's usually completed. And, obviously the advantage is that your husband will fertilize the egg, and that embryo will at least be 50%, genetically identical to you, to the two of you. And you'll obviously give birth to the baby. But so that has an advantage, and it's probably cheaper and less time consuming, but also very successful, 70%.
Mm-hmm. That's good. Yeah. Yeah. And I mean, I'd say the advantage, I guess, to the embryo adoption is if you didn't have a partner, right? And your egg quality was pretty poor. So you're going to need a sperm donor anyway and an egg donor. So I guess.
Well, yeah, that's a good situation. But there are couples who come in who, are at this point or at this juncture, and they want to adopt embryos.
Mm-hmm. Yeah, there's so many ways. I think that's the beauty of it. There's so many ways to this, and I guess that is the choice when someone has several embryos that they're not going to use. Like, what do they do with them?
Yeah, I don't know what's going to happen. If they pass these new laws and things like that. I mean, how that's going to affect all this, I don't know. And those are questions we're getting now, but we don't have any answers on that. We don't know.
No, definitely. Well, and definitely, that there's options as well for someone who's in their early 20s or mid 20s or whenever that it might be. I guess it's a good reason to check the AMH and to make sure that everything's good, because there are techniques now where you
I
can
see.
Drugs,
She's from Venezuela, so she says it's cheaper to go to embryo adoption.
Oh, okay.
Instead of egg donation.
Ah, okay.
Well, yeah. I mean, but that would be the situation to use donor eggs anyway, even with low sperm count, because we can do ICSI on that, and get fertilization. That's what ICSI is invented for. So you could still go through egg donation.
Mm-hmm. Okay. Yeah. Yes, because you don't need that many sperm, right? to create embryos. Yeah. Okay. All righty. And I guess like what you're saying is the rate of success going to embryo adoption. as far as the two transfer failures, no implantation, don't you think you want to make sure that you check the uterus also to make sure there's nothing going on there
Oh,
first?
of course, of course. I mean, I answered it specifically in terms of what she was asking, but yes, of course, she would need a full evaluation for endometritis, biopsies, SIS study, check the uterine cavity, make sure there's no hydrosalpinges in the tubes. So there's various factors. Obviously, the thyroid, blood tests. So there'll be various other factors to look for. But in terms of, those two things, looking at either embryo adoption or donor egg, I mean, that's going to be obviously a personal choice. But the her situation, I guess, it's cheaper for her to adopt an embryo there, I guess, versus creating an embryo between the two, with her husband. So that embryo would be at least half theirs. But maybe it's a lot more expensive there. I don't know how much it is here. Maybe she wants to do it here.
Yeah, it seemed like adoption. I don't know. There's not I looked up that for some patient, and I just couldn't see any pricing on those. But and I wondered about that. Is it as long of a process as actual adoption?
No, it is. It can be. It can be. You think it would be a straightforward thing, but it's not.
Okay. And there is a question about, I just want to get to these that were submitted beforehand. There's a patient who had her second FET in July that was not successful. They are doing acupuncture once weekly now, and they are 37 years old with PCOS with my embryos success rate. Doing acupuncture weekly now. Okay, so I guess the second transfer did not go through, but now they're doing acupuncture once a week. They're 37 years old, and they're using, I think, their own embryos. What is the success rate? I guess you would need more information, but do you have I guess any? That's a really specific question. I don't know. Any idea what you would recommend?
Well, did they do PGT at all or not? We don't know that. I mean, obviously, other uterine factors like we just mentioned. Did they check all that and make sure the uterus was clean? Did they make sure there's no endometritis, that no polyps in there, thyroid's normal, weight is normal, no inflammation like we talked about before? Are all the other extrinsic factors good to go?
Yeah.
To help you implant? Did you maybe should look at the immunology a little bit and see if there's any issues there? Recurrent pregnancy loss panel, looking at the thrombophilias, cardiolipin antibodies, things like that I would probably look at. Maybe natural killer cells too, just to see, although, nobody can say for sure whether killer cell treatment or anything like that was involved in this. But 37, close to 70%, probably 60-ish % of the eggs that you get may be aneuploid. So PGT, if you have a lot of embryos left, and if they have not been PGT, maybe that's a good thing to do, just to make sure.
Oh, Lisette just said thank you. She's commenting. Thank you, Dr. G. Our little miracle is already 12 weeks. You're amazing.
12 weeks.
Always. Yeah. Well, time goes by. Where are you? That's crazy.
Gosh.
I definitely, with PCOS, we talked about inflammation earlier, so that would be something good to check for as well. And
absolutely. So what's your CRP?
Yeah.
Maybe check into those other extrinsics. Get that Quest test.
Yeah.
Find out about that Quest metabolic panel. I can't remember the name. What they're called.
Cardio IQ.
Cardio IQ.
Yeah.
How'd you know that?
Because we do it too. I love that one. Yes, that's a really good.
The Quest one, right?
Yeah, we do. I love for PCOS because it's like we've had patients where the cholesterol is normal, on the regular blood work, but yeah, we do the cardio IQ, and we're like, well, actually, it's not.
Well, you see these large, dense. I mean, it becomes a little bit into the realm of cardiology. you know, where we're sort of maybe stepping into that realm a little bit too much. But, you know, maybe we should, you know, because, you know, we've got to advise patients because they may not be getting the advice anywhere else.
Yeah.
And this is all, you know, now we're just sort of seeing how everything is full circle and everything is interconnected.
Yes. And I mean, and a lot of times we're
And
doing before they see you guys, because there's maybe a few months where they're gonna have
well,
come
yeah, I
out.
mean, it's crazy because now you know, we should become more metabolic physicians,
Yeah.
you know, and we kind of are with what
Hmm.
we're telling patients and looking for. Maybe we should become a little more so with this, you know, cardio IQ panel.
Hmm.
So there's a connection there with, you know, other things that you wouldn't think are connected to fertility. I
Yeah.
mean, for years, you know, whoever thought this field really would evolve so into genetics?
Yeah. Yeah.
I mean, it's evolving more and more into genetics too. We have to become geneticists.
Yeah. No, you definitely are specialists within specialists within a
Well, it's
specialist.
becoming that way.
Yeah, and definitely this I think we had one come back recently that was, we've had a few come back that were pretty alarming that we've referred them to cardiologists.
Oh, for sure.
We've
Oh, for
really
sure. Because you know, you may fractionate the LDL and see a very dense
yeah,
LDL, which is atherogenic, or you may find their ApoA is high,
yeah,
LP little a is high, or these things that can really impact their
yeah.
future.
Yeah,
You
and
know,
that might be a clue of where that CRP is coming, that elevated CRP is coming from, because
right?
that's one of those things. And definitely when someone's about to do a transfer in a few months, you want to do all you can to help with that and
Yeah.
nutritionally and everything. So and sometimes I guess genetics, it is hereditary, some of these things. So
Well, yeah, there's familial hypercholesterolemias and things like that that we pick up on the SEMA4 panels and things like that. So
yeah.
I've referred actually two men who had that,
Hmm.
cardiologists, and one guy actually had a stress test. This was a few years ago, and he had some abnormalities on his stress test. He was a young guy.
Yeah, definitely. And they actually have a phone number you can refer patients to. It's done through the Cleveland Clinic, I guess, this test. So they actually counsel the patient as well if they need to, you know,
From the cardio IQ?
yeah. Hmm.
Oh, really?
Yes.
Oh, that's good to know.
They have a good practitioner line too, because we're not cardiologists, so, and we're not in that specialty.
No, we're
So
not cardiologists. I
I,
mean, the problem is going to be, you know, if you have a really high LDL or some problem there, what to take, you know, as you're trying to get pregnant. I mean, we may have to just deal with it as best as we can. And then, you know, once you're not pregnant, you're going to have to really get aggressive with that. I mean, maybe we can get away with things like Lovasa, which is a drug to reduce triglycerides. You know,
it's also omega 3.
it's a very purified fish oil
Okay. Yeah.
by prescription. I think it's,
Yeah.
yeah, that maybe we can get away with, but you know, anything else like statins, you know, we're not going to get into that.
Yeah.
That's more internal medicine.
Oh, we have a natural killer cell question here. Do you need to treat natural killer cells before egg retrieval if they're elevated, or it's only important to control them before the transfer?
Only before the transfer. And again, you know, that's another thing that actually the ASRM, the Fertility Journal, had a very big series on that. I think it was last month or this month, I think.
Oh, they did? Oh,
Again, questioning the immunology. You know, we are a little bit aggressive in terms of treating elevated natural killer cells, which are not, by the way, important when you do a retrieval. You know, we don't even check them at that time.
mhm.
But it's before transfer because they're involved with implantation. The problem with NK cells in the blood is that it's a different subset of NK cells that are in the uterus. And we don't know what the correlation really is at that. You know, your NK cells can be elevated from almost anything. Maybe you've got a little virus or cold or something, your NK cells are elevated. It has nothing to do with what's going on in your uterus. And nobody's really conclusively shown that, you know, looking at NK cells in a biopsy and things like that is really going to tell you whether, you know, it's going to cause a miscarriage or not. Some people are actually advocating looking at NK cell parameters in women who've had a miscarriage in their menstrual blood.
Oh, right. Mm-hmm. Yeah.
to actually look at it there to see what the profile is there, that probably would be more helpful to see exactly what's going on there. But, you know, I think a lot of times we do treat patients with high NK cells in the blood. We give them intralipids, which is very safe and very side effect free and cheap. But, you know, a lot of times, you know, you don't know for sure whether it's benefiting them or not. And, you know, in somebody who's had elevated natural killer cells, who has other autoimmune diseases, it's probably significant. And the one usually we see is thyroid disease, where they have thyroid antibodies.
Yeah.
In that situation, that's probably a significant autoimmunity going on there. Some of those patients may end up actually getting IVIG and or steroids. Where I think, you know, some of the data, and there's been plenty of studies showing that that works.
Yeah, it's definitely always been controversial, you know, but we can see it clinically with somebody who had a transfer without it, and then they had a transfer with it, the intralipids in their
Well, again, do you really know? No.
Yeah.
You know, there's a lot of other factors with the embryo itself, you know, the metabolics inside the embryo and how the embryo is going to, you know, interact once it's there. Implantation factors may change month to month. There's a lot of things that it could be, and, you know, just saying that we gave her intralipids did the trick. I mean, I'd like to say it that way, but we have no conclusive proof.
No, it's not harmful though. You haven't seen any side effects.
No, it's not harmful. It's soybean oil. It's like going to McDonald's. I mean, some people actually, there was some data or study or something was on the internet that people were actually going to McDonald's and eating a large French fries before their transfer.
Oh, wow.
Soybean
Oh, that's the French fry question. Okay, because I was like, where's the French fries? Where is this coming from? You know,
that's where it's coming from.
Oh,
yeah?
that's a
yeah.
good question.
So,
very nice.
French fries.
Okay.
You can bring the doctor some too. I like them.
Yes, and Allison's saying, thank you for both being part of my team. Very excited. You're anxious for FET tomorrow. And I'll be there tomorrow for you, Allison. I'll be excited, and I'll see you, Dr. Gelman, there as well. And I'm just hoping that, well, we're all going to send you a lot of good energy for tomorrow for that transfer.
Yeah. The whole world is.
Yeah.
The whole world is sending you energy tonight.
Over.
We got people from all over the world.
Yes, definitely. So we're rooting for you. And I think we're almost to the end here. We got like 2 more minutes, so we're going to see if we can squeeze in one more question. Yeah. Actually, there's 2 more little questions here. When do day 3 frozen embryo transfers typically implant?
Well, we don't do day 3 frozen embryo transfers. So
why do you do that? Do they freeze day 3 embryos or no? I didn't think.
No. No.
You know, okay.
No. Everything's day 5.
Yes. So maybe it's a fresh day 3 transfer. Maybe that's what they're thinking. Oh no.
I haven't done one in
many years.
10 years.
But I guess if you are doing it, because I know some clinics still are doing that, it would be several days before implantation would happen then, right? I mean, if you're...
Well, yeah, 48 hours.
Mm-hmm. Okay, and then, let's see.
Nigeria, yay!
Wow.
That's great.
What is the oldest patient that you have helped? I can't read tonight. Okay, what's the patient that you've helped having a baby using your own eggs?
43. 43.
Yeah, and usually after that, you're recommending donor for IVF.
Yeah, I mean, most people by 43 are using donor eggs, but there's been an occasional person here and there.
And it's not to say that you can't get pregnant over 40, because we definitely have seen that. It's just that the success rates when you're trying on your own versus IVF are kind of similar after a certain point, right? As far as
it's about 1%, 2%, maybe.
Let's see. All right, I think we have gotten to, every time I think we've gotten through the questions, there's one more left. So this is the last question.